today. I am very proud of myself. Thank you so much for joining us. I'm here with the one and only Jack, and we're so excited to talk through a case with you all. Does anyone have a case that they want to present? If you do, please let us know while Jack says hi.
Hello, good afternoon, everyone. It's great to see you all. Yeah, I'm jazzed as always to get to think through a case with the one and only Charviz. Please let us know if you have a case, but otherwise, we can go ahead and get started for our Turbo Speed Wednesday 30-minute VMR.
Love it. Since it's 30 minutes and I know Jack is on service, maybe Magdalena, if you want to just present your backup case, that would be great.
Yes, definitely. Okay, so as you said, it's a 30-minute case, so we will jump right in. So I'm actually going to, in addition to the chief concern at the beginning, I'm just going to kind of paint you the setting because it's maybe a little bit more of an atypical setting than what we're kind of used to in some of the other case presentations. So the setting, this is a visit at an outpatient HIV clinic that provides care for people living with HIV experiencing unstable housing in San Francisco. So the clinic is part of a program that provides low barrier access to HIV care. So drop-in visits, incentives for attention and care, things like that. So that's the setting that we're in. And the chief concern is an itchy rash. And I'll give you a little bit of kind of the HPI. So this is a 52-year-old man who is presenting to this outpatient clinic because of an itchy rash that he says is predominantly on his trunk and his legs. He first noticed it a few months ago. In terms of the time course, he feels like it has been getting worse since he started taking his HIV medications more consistently over the past few months. But the rash has really become more bothersome in the last 10 days, which is what prompted him to come to the clinic. So I'll pause there before I give you the rest of the HPI.
All right, awesome. Well, this is a very, very exciting start. So I think, some of the information that we have so far, I think can at least help us to sort of at least organize the way that we're going to be thinking about the development of sort of a progressive rash. And I think rashes are quite challenging to think through with just the history alone, because the morphology of the rash is so critical, right? I think we know that this rash is pruritic, but there's so many other factors in terms of a rash morphology. Like, is it urticaria? Are we dealing with something that looks to be more eczematous? Is it plaques? Is it papules? And so I think understanding more information that we're going to get in the exam is obviously going to be critical here, but we can make some progress with the information that we have. And one of the things is that it's progressing as this individual is taking HIV medications more consistently. And I think one of the things that I would be curious to know, which is data that we may get coming down the road, is what was this individual's overall level of HIV control over the prior to starting to take his medications more consistently. Because when we think about people who are restarting or initiating on antiretroviral therapy, we can see a very, very rapid decline in one's viral load and then a very, very brisk improvement in their overall immune status. And this phenomenon of immune reconstitution can cause clinical symptoms in a number of different areas, right? We classically might think about immune reconstitution inflammatory syndrome, but there are also a number of dermatologic manifestations of immune reconstitution. For example, individuals with HIV who have improvement in their viral load can get something called eosinophilic folliculitis, where as their HIV improves, they can develop sort of a abrupt pruritic rash here. So I think one of the questions that I have in my head is this true and unrelated to the individual's underlying HIV? In that case, we would take our general approach to thinking about progressive pruritic rashes, but also there's the possibility that this is actually related to the improving HIV control. And in that case, we would think about things sort of under the headline of dermatologic conditions that could be related to immune reconstitution, one of which that can be intensely pruritic is eosinophilic folliculitis. I'll leave it there and kick it over to Charmaine to talk us through some of the things that could be unrelated to HIV or anything else that's come into your mind.
Oh, I really, really love that, Jack. So I think when I think about like a pruritic rash, two things comes in mind. Is it like a primary derm issues or is like secondary to more a systemic issue that is going on? So I think in terms of like the skin issues that I think about with prominent pruritus, eczema like atopic dermatitis, contact dermatitis, psoriasis, and dry skin actually, which I think sometimes like we just don't give the dry skin the respect it deserves because it can actually become pruritic too. And like, drug induced as Jack alluded to. And the other things also to think about infection, stable, especially if someone who has unstable housing, then thinking about like, are they more at risk of developing like scabies, lice, bed bugs. So kind of those infections tend to also present a lot with pruritus. The other one to think about, just to kind of more think about like systemic diseases with pruritus that might not necessarily have rash. We think about like cholestasis that is due to liver, like people who have CKD can have pruritus associated with that, endocrinopathies as well. And I think like bunch of like, autoimmune and cancers that I'm not going to invoke just yet because I think it kind of sounds like this patient is probably has a rash associated, but those things spikes my interest if it's like a pruritus without an actual rash. So I'm excited to hear more.
Wow, phenomenal discussion so far. I love how you both are kind of holding both possibilities. Is this, related to the underlying HIV infection we've heard about, or is this separate, primary dermatologic, or part of a systemic disease? I really, really love having you walked through that. So a little bit more about the HPI. We asked him kind of what makes it better. He said he's been using hydrocortisone cream and just a moisturizer, but really has not had any relief from that. He describes the rash as scaly and says that many of the lesions have basically turned into scabs from itching them so much. When asked if he's experienced anything like this before, he said that he used to have a rash mainly behind his knees many years ago that he says, quote, since he was a child, he said those rashes would come and go, but we didn't get much more information about that rash. And then separately, in addition to this diffuse rash that's kind of his main concern on the legs and on the trunk, he also mentioned this concern of a red, firm bump in his right elbow crease that has worsened over the past 1 to 2 weeks and is becoming more painful for him. In terms of other review of systems, it's mostly negative. So he hasn't had any cough, no chest pain, shortness of breath, no joint pain, no fevers or chills. He does report some constipation and straining, but no blood in his stool or any abdominal pain. So I'll give you some more of his past medical history. So he does have a history of HIV infection as well as Hep B and Hep C co-infection. I'll give you a little bit of information about his HIV infection. So he was diagnosed in 1998. And since that time, he's been on and off antiretroviral therapy since that diagnosis, most recently with intermittent adherence to the medication he's on, Biktarvy. So I'll give you kind of the most recent treatment history. So he was completely off antiretroviral medications from 2018 to 2021. He kind of presented to this HIV clinic in 2021 and then was restarted on Biktarvy, the medication. I'll give you more information when we get to the labs, but just for now, so when he started, when he represented in the clinic back in 2021, he had a viral load of 20,000 and his CD4 count was 104. He was then kind of restarted on ART kind of like a month later. And then in January of 2022, his viral load was actually less than 200. And when we get to the labs, I'll tell you more information about his CD4 count. He has a history of some opportunistic infection. So he's had a history of thrush. He's had 2 episodes of pneumocystis pneumonia, and he also had an episode of pulmonary coccidioidomycosis, which was diagnosed when he was incarcerated in the Central Valley in California. Just a little bit about the pulmonary that's a hard word to say, coccidioidomycosis history. He was on fluconazole suppression kind of after that diagnosis, and the plan was for him to take the fluconazole until he got his CD4 levels up, but he has had a difficult time taking that because of the nausea that gives him. And then in terms of his Hep C, the team had been wanting to start him on treatment with Epclusa, but based off of some of the notes I was reading, it seems like he has been wanting to focus on HIV for now, so has not been interested in treatment for that. So maybe I'll just pause here before I give a little bit more information, just to see if you have any questions about that.
Thank you so much, Magdalena. I really appreciate the thoughtfulness around like kind of his past history, especially with HIV, like the number of opportunistic infections that he's had in the past is like really, really helpful to kind of frame for us like who the host and who the patient is. So maybe I'll just like comment a little bit about the additional HPI and then leave the history to Jack to layer on. I think in terms of with the hydrocortisone and moisturizer not improving symptoms, the one thing to always remember is how much did the patient try? Was it just like they did it for like 2 days and it didn't work? But was it like for for a week that they did like maybe twice a day, 3 times a day? Just kind of getting a sense of like if that was actually a lack of response, or was it just like not enough time to be able to make a valuable judgment on whether it was actually helpful or not. In terms of like his childhood skin presentations, I think with childhood like eczema being like a very common things that kids do get, like that goes with like kind of the atopy. Whether this is related to that or not, I think to be determined. It's helpful to know. The other thing about the other thought that I had was like kind of the scab formations. If something is really itchy and people are scratching at it, that can cause scabbing. So as well, so kind of making a distinction of whether that is like wide iatrogenic from kind of being itchy, or is it like part of the rash manifestation in itself. I think the physical exam would be really, really helpful. And I think kind of the lack of other symptoms, constitutional symptoms, makes me think like, hey, is this kind of, it sounds like it is limited to the skin. However, I think we kind of need a little bit more information to determine that. Jack, what are your thoughts?
I really have very, very little to add to what you just said. I think that it's honestly, for me to be totally transparent, it's hard for me to know exactly what to do with the past medical history based off of the description that we have here, because I think it's tough to if we look at the prior, like history of opportunistic infections or the other prior infections that this patient has, Hep B, Hep C, Coxsackie, and thrush, it's hard to necessarily layer any of those on with the clinical syndrome that we have at hand. And so I would say like all of these past medical history features give us, I think, a really, really detailed history of what this individual's background of opportunistic and HIV co-infections have been. But I don't know necessarily that there's any particular hand in glove fit with what we have here. The one piece of information that I think I am a little bit more diligently tracking is this sort of tender nodular lesion on the forearm with the history of known Coxsackie. Because if Coxsackie disseminates outside of the lung, we can oftentimes see a variety of different clinical manifestations, some of which can be cutaneous manifestations that usually include subcutaneous nodular lesions and things like that. So I think this sort of red bump in the crease of the elbow with somebody who's known to have pulmonary Coxsackie that has required intermittent treatment makes me wonder that are we dealing with a dissemination of Coxsackie infection? But we would have to contend with the probability of that in the setting of improving immune function as opposed to worsening immune function. Usually it's individuals who are having progressive immunocompromise, who are at increased risk of disseminated Coxsackie, not necessarily somebody who is immune reconstituting, but it is possible that the dissemination happened a long time ago, and we're seeing the manifestations now as the immune system reconstitutes, this sort of idea of what we call an unmasking iris. But Beyond that, I would say like Hep B and Hep C, right? Those the question becomes, can those be associated with rashes? Hepatitis C certainly can. We can see various rashes. For example, individuals can develop a cryoglobulinemic vasculitis from hepatitis C, but that doesn't usually manifest as a pruritic rash, but usually a non-blanching purpuric rash. Hepatitis C can also put individuals at risk for photosensitive rashes that you may see, for example, on the backs of the hands in areas that are very, very exposed to the sun, or on the face. And so if these rashes on the distal extremities are in areas that are particularly heavily exposed to sun while this individual is outside, then we are potentially dealing, then we could say maybe Hep C is on the hook here as well. I'm blanking on the name of what that rash is, though. If somebody could help me out, the photosensitive rash that people get from hepatitis C, the actual name is just escaping me. Thank you, Sammy. Porphyria cutanea tarda. See, I had a brief episode of global amnesia as this individual is having global pruritus. But otherwise, I think it is going to take really the characterization of the rash on the exam to really help to narrow that. But those are the two features of the past medical history that I'm tracking: the history of cocci and the history of hepatitis C. But how relevant those two factors are could change drastically as the exam unfolds.
Amazing, phenomenal discussion. I've given you so much kind of rich past medical history, so it's really cool to see you kind of consider how much does that influence the current presentation versus not. Okay, so a little bit more information for you here. No known surgical history, no pertinent family history. In terms of social history, I'll start with substance use that he reports. So he reports intermittently engaging in IV drug use and has a history of heroin and meth use. Just to give a little bit more information about that. So last year he had an admission for an unintentional overdose. And after that overdose, that was really the trigger for him to start on methadone treatment and kind of this intermittent Suboxone treatment. He was in remission for a short period of time, but relapsed, and he now states that he continues with methadone maintenance, but still reports some intermittent injection use. Sexual history, he has not been sexually active for several months, but was previously sexually active with women only. For housing, he currently is experiencing unstable housing. About a year ago, he was living in encampments, but most recently, over the past few months, he's been couch surfing with friends and staying in short-term hotels. For his medications, he takes Biktarvy daily and has become more adherent to that medication over the past 3 months. For prophylaxis, he takes Bactrim, and he's prescribed fluconazole as prophylaxis, but he's not been taking it because it makes him nauseous. And then he has the methadone maintenance therapy, which he takes. So for the sake of time, I'll actually jump to the exam. So the vitals, overall stable. So the temperature is 36.1 Celsius, blood pressure 115/78, respiratory rate 16, and he's saturating 97% on room air. So in general, he appears just in distress. He's itching the lesions on his arms and his legs during the discussion, and you can see he's just really preoccupied by that. The rest of the exam is grossly unremarkable. So cardiovascular exam, regular rate and rhythm, pulmonary exam was clear to auscultation. The abdomen was somewhat distended, but more or less soft and non-tender. And then for the skin exams, which I'll describe, unfortunately, I can't show the photos because he has many tattoos. So for patient privacy, I didn't want to show that. But so he has these erythematous macules with overlying scale and crusting distributed on the legs and the trunk, and a little bit on the upper extremities as well. Most of the lesions have a central clearing. And then in addition to that, there is a, in the right antecubital fossa, there's a 2 by 3 centimeter kind of indurated, warm erythematous area. There's no fluctuance at the site there. And kind of we asked him if that corresponded to where he does his injections. He said it was around that same area. And I will, I may just kind of give you some of the most recent labs, just for the sake of time here. So because this is an outpatient visit, we didn't get a CBC and CMP. I looked kind of back at the record, and from the last visits, they were grossly normal. But I did kind of want to give you an update on his HIV labs. So as I said, he has been taking his HIV medications more consistently over the past few months. So I'll just kind of walk through how his CD4 count has changed over the past few months. So back in November of last year, his CD4 count was 104. In May of this year, it was 144. And then most recently in July, it was 266. And his viral load is now less than 30. So that's kind of all the information I have. So I would love to hear what you're thinking at this point, how you would approach treatment as well.
All right. Well, I think that this exam is incredibly helpful because I think it introduces the possibility of there actually being two distinct phenotypes on exam here. It seems like one of the phenotypes that we have is a diffuse pruritic macular rash. And then we also have a more inflammatory indurated region at the antecubital fossa. It is possible that these are all related to one dermatologic condition that we may be finding in sort of various stages of healing / development. But I think the possibility that what we're dealing with is actually potentially a skin and soft tissue infection at one of this individual's injection sites on top of a more diffuse or disseminated rash that could be related to injection drug use or completely unrelated to what seems to be a culprit for the antecubital fossa lesion. I think the exam really, I think, illuminates that possibility here. Just to ask Madalena, was this, I apologize if I missed this, was this a recent case that you saw, or is this something that you saw in the distant past?
No, I saw it like 2 weeks ago.
Okay.
So recent.
So I think, we would be remiss in a young person experiencing homelessness who is in close contact with other individuals just by virtue of his current housing situation. We would be remiss to not consider monkeypox as a possibility for somebody who has this sort of diffuse, intensely pruritic rash. We might expect to see more constitutional symptoms. We might expect to see pain, and we may classically expect to see papular lesions as well. But I would say, like, because I have seen so few cases in person, and because of how underdeveloped my illness script is for it, I think anybody who has risk factors for acquisition from close contact, who has an intensely pruritic diffuse rash, it comes onto my DDX, not by virtue of necessarily having a significant suspicion for it, but by virtue of having an underdeveloped illness script. And so thus my ability to falsify that hypothesis is quite limited these days. And then in terms of the sort of tender indurated antecubital fossa lesion, it does, I think, characteristically have features that we might think of as in terms of a skin and soft tissue abscess. And so the management for that may actually be different than the management for the pruritic lesions involving antibiotics, drainage, and or both. But I would say that feels like about as far as I can take the exam so far, because but I'm curious to learn from the one and only Charmise in terms of other things come into your mind seeing this more diffuse rash syndrome.
Yeah, that's a great thought. And I think, like, kind of training our brains to think about more about monkeypox, I think that is a very astute point, Jack, especially, given, the contact with everybody else. And the one thing that I was thinking about, with the scaling on top, also like the central clearing might not be part of it, is kind of like crusted scabies, like the most severe form of scabies that you can see with, especially in folks who are immunocompromised. That is like kind of the pruritus is very intense, and also it's their burden of mites is really, really high. So I think, like, if I am evaluating this person, given like his immunocompromised status, given his and like common things being common, I would think about just empirically treating someone like this for scabies. Would be like one thought that I had. When I think about like the central clearing of it, the other things that, again, like, I don't think he has kind of the risk factor, or but like Lyme disease, the rash has like a bit of a central clearing to it. Rash, I like the itchiness. I don't particularly associate it with, and like I think any of the allergic responses that I think the chat has been thinking about as well is good would be things to consider. So, I know what this rash is? The answer to that is no. So I think when you don't know, then you want to get more information or get the expertise from someone who knows, or kind of anchored in the base rate. So, and for me personally, like I think like scabies would be the first one that I would think about treating. Jack, any other thoughts?
No, I just I love the thoughts coming through the chat about the possibility of a tinea infection as well.
Mm-hmm. Yeah. Is it infectious? Fungal being part of scabies is another one, monkeypox, or is it more like autoimmune where steroids would be helpful? And I think in reality, a lot of the times we just kind of use treatment as a way of better understanding. But again, like I think what you said, what to think about, these patients' risk factors, getting I'm glad like the CBC and CMP were normal. I think the Coxsackie is a good thought, Jack, in terms of like whether this is like a skin manifestation of Coxsackie that can have multiple different variations. So I think in someone who is immunocompromised, it requires a little more due diligence and a little bit more closer follow-up to see what this is. And I think the indurated one, just to, as you mentioned, like whether this the indurated one in the forearm is different than the rest of the rash, or they're combined, or they're like the underlying pathophysiology is the same. I've been kind of thinking about a local reaction. This is where he injects his and making sure that's not an abscess that is forming, or there's not a retained body there that is causing an allergic reaction if it's like a broken needle or something there. So kind of like thinking a little bit more about that as well would kind of be my next steps. I'm so curious to learn from you, Madalena.
Yeah, amazing discussion. And I think it's so hard probably to discuss a rash when you can't see a photo. So apologies for not being able to give that information. So a lot of what you described were on the differential when I was discussing with the doctors I was with. So the top two differentials were really nummular eczema and tinea corporis. And we spoke with derm colleagues who said that they thought the rash was most consistent with tinea corporis, especially because of the central clearing. And a lot of what you guys mentioned, the immunoconstitution and in the chat, they also said that the tinea may have been exacerbated in the setting of immune reconstitution. So in other words, given his recent increase in CD4 count, maybe his body wasn't reacting to the tinea before, but now is, which is why the patient is saying it's been getting a lot worse. So I'll go into kind of how we went with the treatment, but the kind of working diagnoses at this point were the tinea corporis exacerbated in the setting of immune reconstitution. And then, as you said, kind of a separate process going on in the right antecubital fossa, which was an abscess. So I'll just briefly mention kind of how we approached treatment. So for the tinea, we gave clotrimazole cream twice a day for 2 weeks to monitor for improvement. And dermatology recommended to not give steroids at the time in case it was eczema, because they didn't want to basically muddy the water in case it was all tinea. But potentially, as you said, using treatment as helpful diagnostic tools. If the lesions do not improve with clotrimazole, potentially this could have been an eczema picture. For the abscess, the team decided to give Bactrim for that. And there was, based off the exam, there was no kind of drainable portion for that. And then just briefly for the HIV management. So he's been adherent to Biktarvy. His CD4 is now, 226. For the primary prophylaxis, they actually talked about being able to stop Bactrim for the primary prophylaxis portion because his CD4 is now over 200 and he's been consistent with ARTs. And then lastly, before Promise's amazing teaching points, I just had like a few sentences about Iris because it was kind of a new thing to go back to for me. So as you all have described, iris immune reconstitution inflammatory syndrome is this inflammatory response that occurs as immune function is partially restored in people living with HIV after reinitiating or receiving antiretroviral therapy. And what was new to me is actually half of iris events are dermatologic, the most commonly being either herpes zoster or HSV. But in preparing for this case, I actually found several case reports on iris associated with dermatophyte infections, such as tinea corporis, which was new for me. So that's all I have for the case, but really it was amazing to hear your discussion about how much this current presentation was related to all the history I was giving you. So really amazing. I learned a lot from your discussion.
Awesome. Thank you so much, Madeline. Yeah, it's a really phenomenal case, and I think really does highlight just how challenging. I think dermatologic conditions in general are challenging. Dermatologic conditions in immunocompromised hosts are particularly challenging. But I would say adding on the immune reconstitution here, it's incredibly humbling because we really have all potential phases, right? Is this related to the recently low immune status or the recently improving immune status, or is it completely unrelated to this individual's immune status overall? And I think, as always, a huge shout out to the chat for being on the sent of the case from the get-go, and just another plug for Mukund, who is becoming, I think, a leader in diagnosis in these challenging resource limited settings. And I appreciate, Madalena, you giving the teaching point about tinea associated iris or iris related tinea, because it was something that was actually not on my DDX at all as something that could flare with iris, usually thinking of more of the opportunistic infection. So humbling and educational case as always here, which is what these Wednesday VMRs are all about. Sharmise, any reflections before we kick it over to Promise?
No, absolutely loved this case, Madalena. And yeah, I think getting derm involved, if I were in your shoes, I would have done the same, especially in an immunocompromised host, kind of thinking about also like my own gap on knowledge. I'm like, derm is not my strongest suit. So making sure like you just get other eyes on it. I frequently ask permission to, like, even if I'm on boards, to take a picture of a rash to show it to colleagues who just to double check my own thinking. Again, like so much of it is like pattern recognition too. So getting that extra level of help is awesome. And thank you so much for teaching us, Madalena. I really appreciate it. All right, Promise.
Hi everyone. So thank you, Madalena, first for this wonderful case, and Charmaine and Jack for the amazing discussion, and also the audience for participation. And I have to agree, I am not very good at derm. Definitely got nervous when I saw the chief complain, but it's very educational. And I think that the main things that stood out from this case is this patient is someone who's immunocompromised, and he is homeless with unstable housing situation. So that we really wanted to take a really good history of the social history and his housing situation, and then to really look at if there's any like risk factors with exposure and maybe any kind of infectious causes. And with the rash, we wanted to first think about, ask a lot of questions regarding the morphology, the quality, the time course. Is it progressive? Is it spreading? And then we wanted to know, a big branching point question was, is this like a pruritic rash or not? And we wanted to consider whether or not this would be a primary dermatologic concern, or is it a secondary, some sort of systemic, maybe autoimmune or infectious or even malignancy cause, especially in a patient with HIV infection. And then I think Jack made a really good point when we learned about the physical exam, to kind of separate the two of the anterior cubital fossa versus the rest of the rash, that it could be two separate processes instead of just thinking them as one. And that's kind of where we made some progress of thinking, okay, one could be some sort of infection, like a fungal infection or scabies, and then the other may have just been like his injection use, maybe like a local reaction or is like an abscess there. And I also really liked how Charmin made a point of if you don't feel very confident about a certain area, it's totally okay to reach out for help, calling derm consult to just confirm your thinking and just learn about, continue to build up your knowledge from that. And Madalena also taught us something about iris, which could be associated with dermatophytes infections. Yeah, that's it. Thank you everyone for attending. I hope you have a great rest of your Wednesday.
Love those teaching points, promise. Amazing.
Thanks so much, everybody. Have a great rest of the day. We'll see you next time.